Great. So I'm delighted to be here. Again, I introduced myself yesterday, but I'm Professor Joe Amon at Drexel University School of Public Health. Um, I think it's great to have this talk right after the prison session because this is an issue that I've worked on also quite extensively over the past year or so. And at the start of the COVID pandemic, I was asked to give a talk about COVID and sort of what to expect. And one of the things that I said is that we were going to see outbreaks occurring in a number of different populations, which included, cruise ships, included college dormitories, included military barracks and naval ships, essential workers, and in prisons. And that for some of those populations, there was going to be an aggressive response, and for some of those populations, nothing was going to be done. And we've seen that it's been a complete disaster for essential workers and for prisons in many countries. But also one of the populations that's clearly been neglected is people who use drugs. And I think that a clear takeaway from yesterday's discussions and from today is that COVID-19 has had just a devastating impact on communities of people who use drugs and those living with HIV around the world. But at the same time, there have been great examples of resilience and of the ability of individuals and community-led programs to overcome these unprecedented challenges and to find creative strategies to ensure that people who use drugs are able to continue to access services and be protected from coronavirus infection. And I think it's important to kind of underscore that as something that we take from this pandemic discussion into a post-pandemic discussion, because what it shows is that the structural barriers, the structural determinants, the human rights violations, the criminalization of the use of drugs, the abuses from enforcement of those laws, the lack of adequate funding of harm reduction and social services can be overcome with rights-based approaches, with community-led solutions that are effective, that are not just obligations of government, but are effective public health strategies. And this really, shouldn't surprise anyone, right? Like we've known this before. We're restating lessons that have been learned, but that have often been ignored. And we need to continue to highlight and continue to draw out and continue to insist upon respect for human rights, insist upon engagement and participation of the communities that are directly affected in the response, because it's an obligation and because it's effective. So let me make a few points in this short time that I have. One is that the most fundamental aspect of a human rights approach is to ensure that individuals and communities know their rights. More needs to be done on that in this issue of COVID and this issue of people who use drugs and HIV. Secondly, they should be fully supported to participate in the development of policies and practices which affect their lives and to claim their rights when necessary. When you look at countries where harm reduction services were closed down or scaled back during the COVID pandemic, where harm reduction staff were not considered essential workers, where they were not provided with PPE and emergency funding, this represents a failure of governments to implement a rights-based approach and to respect, protect, and fulfill the rights of people who use drugs. That's a key point. Another fundamental rights principle and key aspect of rights-based approaches is non-discrimination. And non-discrimination is also a key principle of effective public health. We know that if we leave people out, we will not succeed in addressing and overcoming the COVID pandemic and the COVID challenges we face. The next point I'd like to make is that it's impossible to look at the issue of human rights related to people who use drugs without looking at prisons and other closed settings. So just to go back to the last session and go back to other comments, this is key. And the situation in the US in particular, Annette mentioned that there are some 500,000 people who were infected with COVID in detention settings. In the US alone, by the latest figures at the end of March, were that at least 391,782 people in prisons in the US had tested positive for COVID. And through some of the work I've done over the last year, I've seen the testing strategies of prisons and jails in the US. And they are haphazard. They're often non-transparent. They're inadequate. They're not testing in a systematic or in a comprehensive way. And so we know that that figure of almost 400,000 people testing positive is certainly an underestimate of the number of people affected. And in the US, more than 2,500 prisoners have died. The response in the US has been fractured around different levels of prisons, around different authorities. And it also highlights the lack of normative guidance that's being given in the US by the Centers for Disease Control, but also globally. There's a failure to insist upon and ensure and provide clear standards that must be met by prison officials, and that allows them to not uphold and not ensure that protective measures are put in place. There's a lack of transparency also about reporting on the numbers of people that are being positive, what's being done about it, whether there are clear measures being put in place to quarantine detainees on intake, for example. Transfers are occurring despite the risks that introduces COVID into new detention facilities. This is also in the US a population that hasn't been prioritized for vaccination. The Federal Bureau of Prisons secured its own supply of COVID vaccines to ensure that federal prisoners were vaccinated, but the Immigration and Detention Service, which has immigrant detainees who are non-criminal but are being held under administrative charges, did not. So what we're seeing is just this patchwork approach that leaves people behind, that causes outbreaks to continue to occur in US detention centers. And this represents a failure, not just in terms of public health, but also in terms of human rights. Globally, one of the issues that I wanted to highlight was the continued issue of compulsory detention of people who use drugs. And this goes back in 2013, I published a paper with several colleagues in the International Journal of Drug Policy on this issue in East and Southeast Asia. And at the time, according to official accounts, more than 235,000 people were detained in over 1,000 compulsory detention centers in the region. Estimates now sometimes are 400,000 or more, but that's part of the problem, is this issue of transparency and this issue of accountability. What we found in the centers was that individuals were held for a period of months to years. They could experience a wide range of human rights abuses, including the violation of the rights to freedom from torture and cruel, inhuman, and degrading treatment, freedom from arbitrary arrest and detention, a fair trial, privacy, the highest attainable standard of health, and freedom from forced labor. This is 7-8 years ago, where 12 UN agencies came together and issued a statement, including UNODC, WHO, UNAIDS, UNICEF, UN Women, the UN Office for the High Commissioner for Human Rights, and others, condemning compulsory drug detention centers and calling for their immediate closures. But that hasn't happened. We still have these centers. We also have private drug treatment and rehabilitation centers, which operate with varying degrees of concern for human dignity or quality of care, and often with limited oversight, but with funding from state governments. One example of the rights violations associated with these centers that I wanted to highlight is from Brazil, where in 2018, the Inter-American Commission on Human Rights denounced a range of human rights violations, including forced institutionalization, physical abuse, forced labor, violations of religious freedom, among others. And according to the Commission, around 2,000 centers of this kind exist in Brazil, with the government recently granting them $24 million. So one of the things that has been asked for 10 years is that UNAIDS and UNODC create an annual monitoring and reporting mechanism for the number of compulsory drug detention centers and the numbers of individuals detained in these centers. Now, of course, these organizations cannot compel countries to report this information, but they can request it and they can report who provides it and who doesn't. And like with other health indicators, they can also do modeling and estimates and fund research to fill the gaps where no information is provided. Oftentimes, UNAIDS and UNODC actually has information provided by governments, but they've agreed with governments not to publish it. And that's a barrier to having any progress on this issue and to ensuring full accountability for the serious human rights violations that occur within these centers. Recently, the working group on arbitrary detention has taken up this issue, but they have yet to issue a report. But one of the things I wanted to highlight is that the INCB in their submission to the working group said that the board continues to discourage mandatory or compulsory drug treatment. And I think this statement shows the weakness sometimes of the international community in regards to this issue. Where there are violations of the right to be free of torture and cruel, inhumane, degrading treatment, it's not enough that there is a statement saying mandatory or compulsory drug treatment is discouraged. We have to be clearer, we have to be stronger in our responses. As with the issue of the number of COVID deaths, cases and deaths in detention, the starting point is transparency, and the UN has a key role in making data available on the numbers of people in compulsory drug detention centers. It's not the responsibility of academics to report this data, it's the obligation of states to report it and for the UN to request it. Another challenge that has long been recognized, but which has had insufficient progress, is recognizing the social and structural barriers that hinder the access of women and LGBTI individuals to the treatment for drug use. I don't want to go into that. We heard some great presentations this morning on those issues, but it's an important thing to highlight here as well within a human rights context where non-discrimination and the right to health for all is key. And my final point is to the intersection of racism and drug control. In March 2019, the UN Working Group of Experts on People of African Descent stated that the pretext of fighting the world's drug problem has been used to justify excessive surveillance, criminalization, and the targeting of people of African descent worldwide. They also said that it's important to examine the mechanisms, that it's important to be clear that the war on drugs has operated more effectively as a system of racial control than as a mechanism for combating the use and trafficking of narcotics. We've seen clearly with the COVID-19 pandemic how structural racism has shaped vulnerability to infection and death. The point made by the working group further illustrates the intersectionality between race, drug policies, detention, and COVID-19 vulnerability. And I think this is a key point that needs to enter more strongly into the conversation that we're having today. Coming back to Brazil, a study conducted in Sao Paulo in 2017 found that Black people were more likely to be prosecuted and sentenced for drug trafficking vis-a-vis drug possession compared to people who were white. Specifically, in almost 50% of drug trafficking cases involving white persons, the offense was disqualified to drug possession for personal use with a significant sentence reduction, while the same happens in only 5% of cases where the defendants are Black. This is unconscionable. Consider that 2/3 of Brazil's inmate population is Black. The country's correctional system is crumbling and overcrowded, indisputably putting detainees at high risk for COVID infection. Yet over 90% of all COVID-19 related legal cases submitted to the judiciary between March and May 2020 requesting the release of older prisoners and those with underlying health conditions that put them at risk of severe illness and death were denied. Even an injunction issued by Supreme Court Justice Marco Aurelio, issued in March 2020, merely asking criminal court judges to assess the situation of prisoners at risk of COVID-19 in their jurisdictions, was overturned by his colleagues on the High Court. This illustrates the failure to recognize that all of us, whether we use drugs or whether we are incarcerated, that we retain certain rights, including the right to health, and that states have obligations to protect and fulfill those rights regardless. IDPC has also highlighted this issue in their recent briefing paper from March 2021, calling out Colombia and Indonesia as well, where people detained for drug offenses were excluded from efforts to decongest prisons to reduce the risk of COVID transmission. Finally, let me close by saying that human rights have been a central pillar of the United Nations work from its inception, with the adoption of the Charter of the United Nations. And the UN has endorsed the need for human rights-based approaches that require that key rights principles such as universality, indivisibility, equality, non-discrimination, participation, and accountability guide UN development cooperation. Achieving our shared goals related to HIV and to advancing the health of people who use drugs and ending the COVID-19 pandemic require commitment to human rights principles and to rights-based approaches centered around community voices and community-led responses. Thank you.